This conference will now be recorded.
Good morning, one and all. This is today's topic is very important for you, both for theory and practical purpose. Here I'm showing some photos. You should identify and tell the diagnosis. Actually, this is also spotted for you in the exams also, final year exams. What is this child? Anybody? Can you tell the features of clinical photograph features or diagnosis? Chahat. Number 5. What is this clinical photo? What is this? At least.
Ma'am, Downs.
Downs.
Okay. Why do you think so? What clinical features suggest to have Downs in this baby?
Ma'am, protrusion of the tongue, wide spaced eyes.
Okay. And she is the mother. How she is looking? She is the mother of the baby, 9 months baby. Actually, they brought the baby with history of not able to sit without support. 9 months baby not able to sit with support or without support. Not even with support also unable to sit. But only head control came. And the baby is able to recognize the mother. Social smile came at around 3 months. What do you think? Developmentally normal or abnormal?
Developmental delay, ma'am.
Okay. These are all the photographs of Down syndrome babies. You can see. Actually, they are otherwise called as happy puppets. They will be happy, but their IQ will be around 50% only. Moderate IQ quotient and developmental delay will be there. This is the adolescent girl with Down syndrome. But this is not Down syndrome. Why I put this photograph means to differentiate between other conditions which mimics like Down on general examination. Like protruded tongue is there, but there here you can see baby is having forced features, but there is no mongoloid slant of the father-to-preserve. This is a case of congenital hypothyroidism. Okay, today I am going to discuss with you about the Down syndrome, which is a very common genetic syndrome, and also aneuploidy, very common aneuploidy studied in detail. This is the best recognized and most common serious chromosomal disorder, which is usually caused by an extra copy of chromosome 21, otherwise called as, these are called as aneuploidies. Aneuploidy, I think everybody knows, it is not in divisions. Usually, how many pairs of chromosomes will be there in a human being? How many pairs?
23 pairs.
23 pairs. So, if it is in N23, like 23 pairs, 23 into 3, 23 into 4, like that, that we call it aneuploidy. But aneuploidy means odd numbers will be there, like trisomies will come under aneuploidies. This is one of the aneuploidies. Incidence of Down syndrome is 1 in 800 to 1 in 1000 newborns. This is according to OPGA textbook. But in Western studies, it tells about around 1 in 700. That much common genetic syndrome. So, chromosome number which is present in triplicate form. Usually, main cause for this trisomy is meiotic non-disjunction in either maternal side or from the paternal gamete. So, most commonly it's from the mother only, but main cause is meiotic non-disjunction. This is the main cause for trisomy at the chromosome number 21. Coming to the incidence of this Down syndrome, it varies with the maternal age. If the mother age is younger the age, incidence will be less. Older the age, elderly mother. In the first photograph, you can observe mother is very elderly. She is looking around 45 years like that. So, elderly mother, usually there are more chances around 1 in 50. If the mother is less than 29 years, it's around 1 in 1500 to 1550 like that. So if you can remember, that is more than enough. Younger the mother, less chances. Older the mother, especially if the mother is more than or equal 35 years, it's around 1 in 100. If the mother age is more than 45 years, 1 in 50. That much common with the increased maternal age. So here you can observe the karyotype of a child with Down syndrome. I think all of you can observe. This is the chromosome 21. You can observe 3 chromosomes are there. All are having only 1 pair. All chromosomes except 21. Here 3 are there. That's why it's called as trisomy 21. So coming to the cytogenetics. What is the cytogenetics of Down syndrome? Most of 95% of the Down syndrome cases is trisomy is due to. For trisomy, 25% of individuals, usually 3 copies of chromosome 21 will be there. It's almost in 95%. But in case of 1% of the children, it is mosaicism. Mosaicism means more than 1 cell series will be there. That means some cells will contain 23 pairs. Some cells will contain trisomic cells, not uniformly. So clinical features, phenotypical also they won't be like other Down syndrome children. Only some phenotypic features, clinical features will be observed in this mosaicism children. That's only 1%. 4% translocations. Why should know cytogenetics means? Because mosaicism prognosis will be good. Because some normal cells will be there, so they won't manifest clinical features. Prognosis also varies. Prognosis mainly how it recurs in the other siblings next pregnancy. And if it is translocation, there is risk of more chance of risk will be there according to the translocation that chromosomes. Usually translocations will be between 14 and 21 or 14, or 22 chromosomes. These are 13, 15. So these chromosomes are otherwise called as, what is the name given to this translocation chromosomes in the Down syndrome? Robertsonian chromosomes. Okay, 13, 14, 15, 21, 22. You can remember easily also. 13, 14, 15, 21 trisomy, 21 and 22. These are the 5 chromosomes called as Robertsonian chromosomes. Among these, 21 and 22 is more common, translocated to number 14 and more common, followed by 21 and 22. If it is between 21 chromosome and 21, it's a more chance of recurrence, almost 100% recurrence to the siblings will be there. For that purpose, you should know cytogenetics to give the counseling, genetic counseling. They will ask one baby with Down syndrome, other next pregnancy also will be chances of having Down syndrome, more chances they will ask. For that purpose, you should know the cytogenetics. Okay. Why you should know, why you should diagnose and tell the parents of these babies that this baby is having Down syndrome or not? What happens if the baby is having Down syndrome? Anybody? Why you people should learn about Down syndrome?
Delayed milestones.
So there will be delayed development, delayed milestones will be there. Okay. Anything else? So that is developmental retardation. In turn leads to mental retardation also. IQ of these children will be around 50%. Anything else? Physical growth is also retarded because of underlying cardiac malformations. Congenital heart disease is very common. Almost 40 to 50% of Down syndrome children will have cardiac malformations. That is the main factor for the mortality in Down syndrome children. Okay, and also these children are prone for malignancies, leukemias, especially acute lymphoblastic leukemia and myelogenous leukemias are more common in these children than compared to the general population. Not only that, Alzheimer's disease usually occurs after 60 or 70 years. It's common, it may occur around 25 to 40 years also. Alzheimer's, amnesia, dementia condition. That's usually associated with the aging process, usually seen in above 60 or 70 years will be seen around 25 to 40 years. Before fourth decade, we can observe. And also these children are more prone for some skeletal abnormalities, hypotonia, joint laxity, atlantarsal dislocation, which can lead to cervical cord problems. All those are more common. For that purpose, you should learn and you should suspect the child with Down syndrome and have to advise for karyotyping and genetic counseling to prevent further damage and give the support to the family and early stimulation. Very, very important. As already discussed, development delay is very common. So we have to diagnose and give early stimulation. So they can live up to normal life expectancy, but here life expectancy is very less, is around 50 to 55 years only. For that purpose, you should know and you should diagnose and give early stimulation and give genetic counseling to avoid further pregnancies with Down syndrome. So coming to the clinical features, the child may be having mongoloid face, that is upward slanting of the palpebral features, brachycephaly with a flat occiput, small head, flat round face, depressed nasal bridge. I will show you the pictures also. Don't be worry about this. There will be inner epithelial folds, protruding tongue. Here is not the large tongue. It's due to small mouth, as already discussed when we are discussing about congenital hypothyroidism, where it's due to macroglossia. Here is the normal size tongue, but due to small mouth, it is microstia. It will be protruded and small ears. That is microtia. Usually abnormal also, they will have hearing defects. Ocular manifestation, brush spots in the iris, congenital cataracts, nystagmus and strabismus. These children may have hypertelorism or hypotelorism. Don't confuse, because Down syndrome can manifest with hypertelorism or hypotelorism. You can observe in the photographs also. I have shown you two photos, these two also. Here is the hypotelorism. Inner canthal distance is less. Here more. You can compare these two photographs. Okay, this is hypertelorism. This one is the hypotelorism. So both can be observed in Down syndrome in some individuals. Blepharitis, keratoconus, refractory arrest, attacks after 25 years of age. Usually, of course, after 50 years later. But here in Down syndrome, senile features comes early, so early aging will be there. That's why they develop cataract after 25 years of age. And here small, that is microtia with deafness, sensitive deafness, and the conductive deafness also. Coming to the dermatoglyphics, we call as hand and feet. If you see simian grease, that is single palmar grease, short broad hands, clinodactyly, that means incurved and short little finger. That is called as clinodactyly due to hyperplasia of the middle phalanx of the fifth finger, that is incurved and short. And there will be gap between the first and second toes, that is called as sandal gap. You can observe in the photographs, clinical photographs, I will show you. And distal position of palmar axial triradis, that is called as ATT angle, that is distally disposed. These are dermatoglyphics. You observe the palms and soles of these Down syndrome children. You can observe these. And if you come to the examination of these digits, loops and holes will be there in every digits in normal individuals also. Here, ulnar loops are present in all digits. Okay. Next, come to the central nervous system problems, mental retardation, hypotonia. These children will be hypotonic, abdominal distension will be there, joints also very lax, and autistic behavior, these will develop later. Reactive depression in adolescents, Alzheimer's disease, as I told you, usually may occur anytime from 25 to 40 years of age. And the very, very important problems are congenital heart problems. So cardiovascular congenital heart disease, and almost 40% of the cases will have congenital heart disease. Among these, which is common, endocardial cushion defects. Almost 40 to 60% of the cases, endocardial cushion defects will be there. These are the entrance bits. If you can remember, you can underline it. So, common congenital malformation in Down syndrome is endocardial cushion defects. What do you mean by endocardial cushion defects? Anybody? Monica? Monica is there? What is endocardial cushion defects? What are those? Endocardial cushion defects means what? It constitutes what problems? What defects otherwise? Anybody?
The membranes, pre-aortic membranes or something.
Ventricular canal defects. Endocardial defects means atrioventricular canal defects, usually that manifest with septum primum type of ASD. Septum primum, you know, if you go for that, if you go back to development of intraventricular endothelial septum, there will be septum secundum and septum primum. Septum primum appears first. So septum primum is a down at this. So the septum primum defects at the AV valves. So there will be associated mitral valve incompetency also. So septum primum defect with atrioventricular cushion defects will lead to this endocardial cushion defects. Usually they manifest looks like mitral regurgitation murmur also will be the pan-systolic murmur. They're more prone for infective endocarditis. Septum primum is more for infective endocarditis, but secondum type, that is secondum ASD. Infective endocarditis is very less and they won't manifest up to second decade. But if it is septum primum defects, usually type of ASD, usually they will manifest in first year itself. Okay, that you have to remember. These are for entrance purpose. You can remember. So most common is the endocardial cushion defects, that is atrioventricular AV canal malformations with septum primum type of ASD. And then next followed by VSD, that is ventricular septal defect, PDA, tetralogy of Fallot, secondum ASD, simple pulmonary stenosis. These are less common. This is the most common endocardial cushion defect. Are isolated aberrant subclavian artery. These are the congenital heart problems in the child with Down syndrome. Presence of heart disease is the chief factor in determining the survival of the child. So if the child is having endocardial cushion defects, there is no chance of death due to congestive heart failure, death due to infective endocarditis, all problems unless it is corrected. And tetralogy of Fallot also, you know the prognosis. Others, okay. So that's why you should screen all children with Down syndrome. The newborn period, again, before 9 months, we have to identify and correct the underlying congenital heart disease to increase the survival of these children. Next, coming to the important system affected is the gastrointestinal system. Here, almost 12% of the cases there will be chances of atresia of the gut at any level. It may be at the duodenal level or esophageal level or anal atresia. And these children also more prone for Husband's disease and they're more risk for, to develop annular pancreas. So these are GIT symptoms. Usually they will be asked in the exams, especially when you are at the X-ray table. Usually there will be X-ray with Husband's disease. They will ask what is the Dennis syndrome associated with Husband and Down syndrome. And genitalia, usually small penis, cryptorchidism is there. That's why all children, may especially boys with Down syndrome are infertile. Sterility is the more common, but girls, they may become pregnant in the later years, but boys, because of small penis and cryptorchidism, more chances of sterility will be there. Coming to the immune system, they're more prone for infections and trace element deficiencies, and also autoimmune diseases, celiac disease. These are the problems with immune system. So there is multi-system involvement. Down syndrome children, that's why you have to give genetic counseling. You prenatally or antenatally detected early, we can give advice for medical termination of pregnancy also. Endocrine systems, congenital hypothyroidism is more common. Later also the more chance of develop acquired hypothyroidism due to autoimmune process. So you should screen these children at birth and later also for thyroid problem, especially hypothyroidism at any age they can develop. So because already Down syndrome children are mentally retarded, there is associated congenital hypothyroidism if not diagnosed, more mental retardation will be there. For that purpose, you have to screen them and treat the hypothyroidism to increase the IQ levels. So as I told you, girls are fertile, but boys always sterile. Next, coming to the musculoskeletal system, hypotonia will be there, joint laxity and short stature, dislocation of patella, and they're more prone for, because of joint laxity, they're more prone for patellar dislocation and dislocation, and there will be small pelvis. As I told you, because of malformation, atlantoaxial dislocation or subluxation is very common. So you have to screen for that also by taking X-ray cervical spine in lateral view, both in flexion and extension. And there will be 12th rib abnormality, especially absent of 12th rib, or rarely rudimentary 12th rib will be there. So present means it's rudimentary or absent. This is also entrant rib. Only 11 pairs of ribs are observed in following conditions like that. They will ask, that is Down syndrome also one of the conditions. Coming to the immunological system, the neonatal higher incidence of acute leukemias in newborn itself, they more prone for acute leukemias, congenital thrombocytopenia, and neonatal jaundice. These are more problems with Down syndrome babies. And coming to the dental eruption will be delayed. That is delayed dentition. Small and malformed teeth will be there. Mid-facial hypoplasia will be there. Because of that also there will be small and malformed teeth and small mouth. Aplasia of enamel, congenital absence of various permanent teeth also will be there. Malocclusion, periodontal disease. Because of small mouth, microsphere, there will be malocclusions and periodontal diseases. These are problems are more common with Down syndrome children. And this is a summary. You can remember this from head to toe or top to bottom. Physical growth failure will be there. And you can see the head, flat, face, slanting, upward slant will be there. This is like upward slanting. Other features, that is the mongoloid slant. Epicanthal folds will be there, and short nose and depressed nasal bridge. Flat back, occiput will be flat. Abnormal ears, small and abnormal ears is very common, and loops on the tips of the fingers, and single palmar crease is there. Unilateral, bilateral absence of one rib, as I told you. Chest, usually 11 pairs of ribs will be there, or rudimentary 12 ribs. And intestinal atresia, duodenal atresia, esophageal atresia, anal atresia, Sun Springs disease, annular pancreas. These are the GIT problems. Because of hypotonia, there will be umbilical hernia, abnormal pelvis, small pelvis, and diminished muscle tone, generalized muscle tone. And here you can see small and arched, big and wingle tongue, dental anomalies are more common. And congenital heart disease is very common, especially endocardial cushion defect. 40 to 60% of the children will have endocardial cushion defect. And enlarged colon, that is Springs disease. And there is here you can observe there is a gap between the big toe and second toe, first and second toe, that is called as sandal gap. So these are otherwise called as Hall's criteria. 10 critical signs of Down syndrome. Don't mention as Down syndrome. It's Down syndrome only because Down is a scientist who identified the clinical features of this genetic syndrome. And his name it is called as Down syndrome, not Down syndrome only. Okay. These are the criteria, Hall's criteria. Usually will be present key features. That is oblique palpebral features. That is upward slanting the eyelids. And dysplastic ears, small and dysplastic ears will be there. Excessive skin on the back of the neck. Flattened features, flat occiput and flat face, rounded face. Single palmar crease on either hands. It may be there in both hands or one single hand also can be there. Dysplastic middle phalanx on the of the fifth visit of the either hand, that is leads to phalanodactyly. Hyperflexibility of the joints, muscular hypotonia, dysplastic pelvis, small and dysplastic pelvis, absence of morosuplex in the newborn. These are the newborn features, cleaning. So we have to go for the karyotyping, and we have to counsel the parents. So here is the elderly mother. You can look at here. She is looking elderly, usually around 45 years. And this is the baby with both physical and mental retardation. Even though 9 months, baby is not able to sit with support. So here is, you can observe adolescent girl with flat faces, mongoloid slant. You can observe mongoloid slant. Okay, downward is called as anti-mongoloid. If it is like this, that is called as downward. This is like this. That's why mongoloid slant. Anti-mongoloid usually seen in case of Fraser-Collins syndrome, where there will be abnormal ears and hearing defect. Here you can observe it's a trisomy chromosome 21. They're more prone for Alzheimer's disease early, before 4th decade only, and dysmorphic round faces, learning disabilities. Mean IQ will be around 50%, as I told you. Moderate IQ only, development delay will be there. Here you can observe epicanthal folds, brush field spots on the iris, small ears, flat occiput, protruded tongue. You can remember, if you remember that this figure. Single palmar grades, and incurved little finger, cyanodactyly. Little finger is incurved due to, and also absent of middle phalanx of the fifth finger. You can observe the gap between the first and great toe, that is called the sandal gap. And cardiac defects, as I told you, 40 to 50% of the babies will have congenital heart defects, especially endocardial cushion defects, followed by VSD, PD, and ASD. Respiratory, because of the underlying congenital heart defects, they are more prone for respiratory tract infections. and also their immune system is also not functioning, so they are more prone for recurrent respiratory infections. Diurnal epilepsy you can observe as a double bubble sign in the X-ray chest, and they are more prone for leukemias. In newborn period itself, they are more prone for acute lymphoblastic leukemia. In later days, myeloproliferative disorders are more common, and hypothyroidism also there. Atlantoaxial subluxation or dislocation is also common. You have to screen for them before sending to, if they want to participate in Olympics or any other games. We have to screen, and the doctor have to certify that they are not subluxated or instability is there. So here in this photograph you can observe epicanthal fold cycle. Upper eyelid skin covers fold covers the inner corner of the eye. This is epicanthal fold. Okay. Brush field spots means iris there will be white spots. You can observe here it is there, here, here. These are the white spots on the iris called as brush field spots. These are the entrance bits also. They will ask all other features of Down syndrome except like that. Unless you remember that these points, you can't answer for PG entrance. And flattened nasal bridge, short neck, you can low set and small folded ears. Visual associated sensory neural or conductive hearing loss. Flattening, we can see slanting palpable features, that is mongoloid slant. Okay, all of you able to see this picture? Is it clear?
Yes, ma'am.
Yes, ma'am.
మ్యామ్ వాయిస్ వినిపించట్లేదు మ్యామ్ మీది.
This conference will now be recorded.
Okay, we'll continue here. I think all of you can see this.
Yes, ma'am.
Is it audible? Is it
Yes,
audible?
ma'am.
Okay, is it audible? Okay,
Yes, ma'am.
Monica, will be screen share. Screen share will be down. Okay, okay. Maximize this picture. So here you can see the epicanthal folds. Tools ఏమైనా ఉండవా ఇంట్లో డ్రాయింగ్ టూల్స్ చూపించడానికి ఉన్నట్లు. ఆరు 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 ఉంటుందా? Here you can see upward slanting. Okay, epicanthal fold here. In magnified view, you can see upper eyelid skin. Skin fold is covering the inner canthus of the lower lid. So this is called as epicanthal fold. Here you can see the brushbill spots, white dots on the iris. These are called as small, typically white spots arranged in a ring. That is called as brushbill spots. So these are the facial features of Down syndrome. Surya, మళ్ళీ అవుతుంది ఏంటిది మళ్ళీ మూవ్ అవుతుంది ఫొటోస్ ఉన్నాయి ఫొటోస్ చూపిద్దాము. Okay. So here you can see flattened nose and face, upward slanting. Mainly this dermatoglyphics. This is a single palmar crease of the hand. If there is a single palmar crease like this horizontally, this is a single palmar crease. And here you can see increased gap between the first toe and second toe, that is saddle gap. And also there will be some groove also sometimes you can observe. Here also deep crease will be there in case of, and excessive skin creases will be observed in case of Down syndrome. So coming to the prenatal diagnosis of Down syndrome, maternal serum markers very, very important, because as you already know what are the clinical features, what are the complications, multi-system involvement will be there. As I told you, prognosis also very bad. Usually average like life expectancy will be around 50 to 55 years. So these many complications, multi-system involvement with low survival rate, parents usually opt for the prenatal diagnosis and medical termination in case of next sibling. So for that purpose, you should know. And otherwise, elderly primates, some maybe due to some reasons, they may not become, they not got pregnancy before 35 or 40 years. Then they will be anxious about the Down syndrome. So that will be precious, and you should explore the Down syndrome. For that purpose, you should do prenatal diagnosis. What are available? These are the maternal serum markers like alpha beta protein, unconjugated estradiol, human chorionic gonadotropin, and pregnancy associated placental protein A, that is PAP. So these are four, otherwise called as quad test or quadruple test. So alpha beta protein is decreased, unconjugated estradiol is decreased, and pregnancy associated placental protein is also increased, and HCG is increased. This is entrance. This also entrance weight. What are the components of quad test, quadruple test? What are increased? What are decreased? So these are the serum markers. And coming to the amniocentesis, we can go as early as 11 to 14 weeks. We will do amniocentesis intra-abdominally or transvaginal route, and karyotyping and cultured amniocytes we can do. And conventional, usually 14 to 16 weeks. That is fish or null cultured cells. What is fish? What is fish? What is the abbreviation of fish? Anybody?
Fluorescence.
Fluorescence? Fluorescence institute?
Hybridization.
Single selective hybridization.
Okay, so these techniques will give the karyotyping even in the antenatal period as early as 11 to 14 weeks. And we can go cardiocensis, that is umbilical cord blood, we can take at around 18 to 20 weeks, and fetal lymphocyte and culture of karyotypes. Take the fetal lymphocytes for culture for karyotyping, and fish technology, we can see the karyotyping. Or cardiocensis around 18 to 20 weeks, also fetal lymphocyte, culture for karyotyping, same. These are the techniques antenatally, along with other things we can. Chorionic villus sampling can be done, direct preparation or short-term culture of karyotypes. Ultrasound of the ultrasound through the transabdominal route, transvaginal route here as early as 11 to 20 weeks. So ultrasound, we can see the nuchal fold thickness. If it is more than 4 millimeters, nuchal fold thickness at around 8 to 12 weeks. With other signs like double bubble in the abdomen that indicates duodenal atresia, choroidal plexus papilloma, decreased interorbital distance, that is hypotelorism. If it is increased, we call as hypertelorism. Decreased interorbital distance, we call it hypotelorism. And short femur, clinodactyly, macroglossia, absent nasal bones by 8 to 12 weeks, echogenic focus in the bowel, or echogenic focus in the heart. These indicate some malformations. So along with other serum markers and ultrasound, commonly gives more likely, or otherwise we will do ultrasound, then we will go for the serum markers depending upon that. Fetal echo, it usually indicates atrioventricular canal defects or endocardial cushion defects. And fission, that is fluorescent in situ hybridization technology in fetal cells in maternal circulation. Recent one is finding fetal DNA in the maternal serum is indicative of Down syndrome. According to recent Nelson and Opigel, the recent diagnostic test is finding free fetal DNA in maternal serum. So coming to the screening test, what is the predictive value and false positive? Serum markers, maternal serum markers like pregnancy associated placental protein A, pre-beta HCG, that is human chorionic gonadotropin. You do these two, this is 65% predictive value of Down syndrome. And there is chance of false positive in 5%. And nuchal fold thickness alone is more than 4 mm, and ultrasound is around 57 to 73%, and predictive value and false positive around 5%. So previously, triple test they used to do only alpha beta protein, human chorionic gonadotropin, and estradiol. That is triple test. If it is in addition, inhibin A levels also measured, then it is a quad test or quadruple test. Usually individually 69, 76. If it is along with ultrasound, more chance of around 85 to 90% we can predict. Confirmatory test, chorionic villus sampling around 8 to 11 weeks of gestation under ultrasound guidance, and analysis can be directly done on the specimen uptake by using fish technology, that is fluorescence in situ hybridization technique to detect Down syndrome in the cells. If there is a trisomy at the 21 chromosome, that confirms the diagnosis. Advantage of this chorionic villus sampling is we can do it early, and early termination of pregnancy without any health hazards to the mother. We can do. And fetal umbilical blood sampling has to be done after 18 weeks only, and the fetal blood cells we will collect and subject to chromosomal culture. And fetal cells in maternal circulation, in the first trimester, fetal cells can be isolated from the maternal circulation by flow cytometry, and use chromosomal analysis using fish technique or polymerase chain reaction. Fetal DNA, as I told you, it's a recent one. Fetal DNA in the maternal serum suggestive of Down syndrome. Coming to the counseling, very, very important, they may ask you for 2 marks or 4 marks. Genetic counseling in Down syndrome children. Parent of Down syndrome should be counseled with tact, compassion, truthfulness. You should not give false assurance also. You should not exaggerate the complications or multi-system involvement. So you should be tactful and you have to be truth also. You should not give false assurance to any child, any mother with any mentally, developmentally retarded child. You have to be truthful. Parents should be told about the associated problems and the importance of early stimulation should be highlighted because these babies will have hypotonia and joint laxity. So obviously gross motor milestones will be delayed. So early stimulation techniques will improve the tone of the muscles and stabilization of the joints will lead to development of gross motor and fine motor milestones. And risk of Down syndrome increases with maternal age. We have to give counseling. So according to the maternal age. Above 45 years, there are more chances around 1 in 28 to 1 in 50. And after cytogenetics, as I told you, there is a translocation risk in the subsequent live births is more chances. So here you can, this is a tabular plot. Depending on the translocations, if there is a translocation between 14 and 21 chromosomes, the parent carrying the translocation is the mother. There is a 10% risk. These are for entrance. PG entrance, if you can remember, and or otherwise write down in your notebook. And father, it's 2.5% risk of offspring to be with Down syndrome. If the neither parent is having a translocation with de novo, less chance, less than 1%. And if it is translocation between 21 and 21 chromosome, then 100% risk of offspring. For subsequent pregnancies also, they will have Down syndrome baby only. There is a translocation between 21 and 20. So there is a translocation up to baby's karyotyping. Parental karyotyping is also must to give genetic counseling. So how to manage these children? We have to suspect, we have to confirm with karyotyping, and we have to give genetic counseling. In child with Down syndrome, we have frequent pediatric preventive health care. As I told you, what are the problems they may face in the future, like congenital hypothyroidism or acquired hypothyroidism and other system involvement and cardiac problems. They may not manifest at birth. Usually congestive heart failure in endocardial patient defects, they may manifest around 4 to 6 weeks like that. Infective endocarditis at any age like. So we have to follow up them and axial dislocation. They're more prone for visual defects, like refractory errors in the early age and after 25 years, cataracts and hearing defects. All those should be screened and proper treatment should be given to improve their learning skills. An interval history should be directed at identifying recurrent respiratory or ear infections. They're more prone for recurrent respiratory infection. Constipation because of heart springs is a sign of heart springs. We have to deal with this surgically. And for measuring the growth parameters, we should not use the normal the WHO growth charts as per normal birth weight, normal children. We have to go for the special growth charts for the Down syndrome. According to them, only we have to compare with the Down syndrome baby. So there is separate growth charts for Down syndrome children. And we had because these children will be more prone for growth retardation because of failure to thrive, and there is underlying congenital heart disease. These children will have hypothyroidism, whether it's congenital or acquired, and poor nutrition status. All this will lead to growth retardation. That's why you should not compare with other children without Down syndrome. You have to take Down syndrome children charts only. Special charts will be there. And developmental testing and hearing loss and vision screening should be performed every year. And thyroid studies should be done particularly in the in newborn period and especially pubertal age. And you have to treat accordingly. Obesity, they're more prone for obesity. It should be identified early and treated with combination of exercise and dietary restriction. Depending upon the other features, we have to take first initially plain X-ray lateral view of the cervical spine, both in the flexion and extension view. We will suspect any subluxation or dislocation. MRA will be the confirmatory. You have to fix that Atlantic axial joint. Otherwise, it may, if it is prone also, you have to fix. Otherwise, they may go for the dislocation of Atlantic axial joint and it can cause the cervical heart problems. So it's a team approach. Ophthalmic ophthalmic surgeon, ENT surgeon, orthopedician, pediatrician, dietitian, cardiologist, all combinedly, physiotherapy, early stimulation, they combinedly manage the child with Down syndrome. Interlogical screening also should be done every yearly to diagnose early diagnosis of autoimmune origin of anemias, nutritional anemias, and leukemias. Okay, any doubts? Any doubts are there? Any doubts? There are no doubts? Then we will end the session. Pavan, is it audible?
Yes, ma'am. Yes, ma'am.
Respond అవ్వట్లేదు. Okay, doubts ఏమైనా ఉన్నాయా?
Ma'am, pattern of the exam.
Excuse me, I'm unable to hear. Be loud.
Ma'am, pattern of internal assessment exam.
Actually, given the syllabus, till now we don't know whether it's offline or online. Principal sir has to give guidelines after he gets information from the Indian University. Until then, it's scheduled dates only. Prepare for online. Most probably online, but they're not confirmedly told us it's online or offline because your batch is a very huge batch. We can't conduct offline in any examination hall. Social distance we can't manage. No, principal sir has to give the guidelines. Till then, think that it's online only, but not confirmed. Okay, I will let you know if I get any information. I will inform to
Okay,
Pavan.
thank you, ma'am.
Any doubts other than this? Is it clear? Down syndrome very common. So we have to suspect and confirm. You should know what are the problems they will have. Okay.
Yes,
Then we
yes,
will
ma'am.
leave the session.